بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, dear colleague, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in the 33rd session of the IMC Family Medicine Club that we have started 3 years or maybe 4 years ago. And our intention always just to provide you with updated evidence-based materials in different topics of primary care that will highlight your role as a competent physician and as a competent healthcare provider in the different fields of the primary care practice. And of course, from time to time, we try to search for certain topics that match the reality of our interest to tackle certain clinical entities. Of course, we know that vaccine preventable disease is one of the major contributing clinical issues that we have to defend our community by providing the preventive measures in terms of vaccines. And before that, we should be fully aware of the disease itself, the symptomatologies, and even the diagnosis, and then the treatment will take place in order to treat those patients in early stage. But again, we have to go all the way to the preventive measures, which is the vaccines, which will make the whole landscape of managing those diseases entirely different. So today we are going to talk about the preventions of herpes zoster in adults. And truly speaking, there is a huge and remarkable trend now to talk about herpes zoster. And this initiative has been started 2 years ago. And there was a huge campaign to aware the public, but at the same time to put the physicians and the healthcare providers in the position of responsibility and accountability to tackle this kind of disease. So today, this will come to highlight your role as a healthcare professionals who is handling these, especially nurses in primary care and in family medicine. So I hope that this session will be quite enlightening for you, especially we are being blessed by having a group of eminent speakers in the field. So without any further ado, I would like to start by introducing our first speaker, who is Dr. Badr bin Hamd. He's a consultant family medicine and the chairman of family medicine department in the International Medical Center. And he's the chairman of the Credential and Privilege Committee in the same hospital, a member of the organizing and scientific committee for the family medicine clubs and conference. And he has both Saudi board and Arab board and a master's degree in the medical educations. Of course, Dr. Badr has a lot of contribution in the trainings of the post-graduation trainees in IMC and elsewhere. And he is a member of the Saudi Society for Family Medicine. So the presentation will be about the prevention and the management of herpes zoster vaccine. And before we start, I would like to extend my thanks to all of you for attending this session. And I would like to also extend the thanks to the Saudi Society for Family and Community Medicine. Special thanks goes also to FEXIS, ملتقى الخبرات لتنظيم المعارض والمؤتمرات, for organizing this. And big thanks to GSK company for sponsoring this event. So I hope that this session will be quite interesting for all of you. And on your behalf, I would like to leave the floor for Dr. Badr bin Hamd to start his presentation.
Okay, Bismillah ar-Rahman ar-Rahim. Good evening, everyone. Thank you, Dr. Ashraf, for your introduction, and thanks for the organizing committee for inviting me to this great scientific meeting. I hope my presentation will be informative, fruitful, and meet your expectation. So, talking about herpes zoster. So as we know that herpes zoster or the varicella zoster virus infection will cause two clinically distinct diseases. The first one is chickenpox. The second disease, which is herpes zoster, also known as shingles, and results from reactivation of latent varicella zoster that gain access to sensory ganglia during varicella. Also, herpes zoster is characterized, as we know, by a painful vesicular eruption, which occur in a single or two dermatomes sometimes. So as we can see, this is the typical picture of herpes zoster that usually we see in our clinic, but of course sometimes we see different pictures, different presentation, and sometimes atypical presentation for some patient. So we know that once chickenpox rash developed, the virus which is present only in the skin vesicle is postulated to infect the nerve ending in the skin and move retrograde along sensory axon to establish a lifelong latency in neuron within regional ganglion. If reactivation occurs, so the virus can spread within the ganglion to involve multiple sensory neurons and subsequently spread integrate down the sensory nerve to establish infection in the skin and cause the typical rash. So following reactivation, and this is the steps. So we have the latency period, then after reactivation. So following reactivation, the involved sensory ganglion typically exhibit an intense inflammation accompanied by sometimes hemorrhagic necrosis of nerve cell. And this neuron damage, it's the main responsible of the neuropathic pain. So what about epidemiology? Let us talk about little bit about the incidence and prevalence. So we know that in the United States, herpes zoster occur in almost more than 1 million individuals annually, and the CDC estimate that about 30% of the patient of the population in the United States will experience herpes zoster during their lifetime. Also, we know that the incidence increase with age, and the incidence of herpes zoster increase worldwide, and still the causes is unclear until now. There are some risk factors, as we will see in the next slide, that could contribute to herpes zoster. So one of these risk factors is age. We know that herpes zoster is more in patient or individuals 50 and above, but still we are seeing some cases below 50, we are seeing cases in 30 and 20, and sometimes in pediatric. Of course, immunosuppressive patient or patient in chemotherapy or malignant cases, all of these are risk factors to develop herpes zoster. So as we mentioned that age is the most important risk factor to develop herpes zoster. A dramatic increase in the age-specific incidence in herpes zoster begin almost, we're talking about 50 years of age, and almost 20% of cases occur between 50 and 60-year-old. And here comes the importance of vaccination, and we will talk about it, inshallah, in the coming presentation. So globally, older patients account for most medical consultation and hospitalization. Yes, sometimes herpes zoster patient can be hospitalized if the disease is disseminated and severe, or the patient is immunocompromised. So sometimes those patients could be hospitalized. And we know that the severity of disease and the likelihood of complication, including post-herpetic neuralgia, also increase with age. What about transmission? We know from our practice that transmission is mainly by direct contact, but also there is the disease can be transmitted also via airborne transmission. Also, they found that the lesion considered non-infectious after 7 to 10 days, and this is, we can tell that almost this is the duration usually, and most of the patient will have a crusted lesion after the 7 days. So mostly 7 to 10 days after that, the patient could be non-infectious. But what is interesting that the virus DNA can be detected in the saliva during herpes zoster infection, and almost this will last usually for 15 days. Also, people with herpes zoster can transmit the virus causing chickenpox in contact who are varicella naive, those who never had varicella or they didn't receive the varicella vaccine. This is another important point in the prevention part. So while we are discussing with our patient, we should mention this important information so we can prevent the transmission of the disease. Moving to talk about the clinical manifestation. The two most clinical manifestation is rash and pain. But what brings the patient to the clinic is not the rash, but it is the pain, the severe pain that the patient is experiencing. Almost 20% of the patient will have other diseases or clinical presentation like headache, fever, malaise, and fatigue. So let me talk a little bit about the rash. So I will go through a small journey or little journey about the rash. So as we know from our practice that our body is having different, or let me see, I believe, yes. So it's divided to different dermatome in the anterior part starting from head to toe. So the rash starts as erythematous papules, as we can see here in the picture. So this is erythematous papule, and this is the most common presentation. And the dermatome distribution corresponds to the sensory field of the ganglion involved. Sometimes, as we mentioned, the rash can involve one dermatome, sometimes it will involve two dermatomes. Okay? So this is the second stage. So within several days, group vesicles or bulla are the predominant manifestation, the upper picture, and this is the second most presentation after maybe 3 to 5 days from the starting of the rash. In my practice, and I didn't see that much patient with pustule, and this could be the third stage of the herpes zoster rash. Hemorrhagic rash. This is a rare case, but it could happen especially in elderly patient or immunocompromised patient. I believe this is rare. I didn't see it in my life. Maybe we can discuss these cases in the next case with or next presentation with dermatology. So in immunocompetent host, the lesion crushed by 7 to 10 days, and there are no longer considerable infectious. And this is, we know it from our practice. Scarring and hypo or hyperpigmentation maybe persists for months or years, and the development of new lesions more than 1 week after presentation let us think about and mainly underlying immunodeficiency. So this picture will show us the crusting as we can see in the right side, and the hyperpigmentation post-infection in the left side. On these cases in hyper or hyperpigmentation can be short management with dermatology because the patients sometimes, especially female, will ask for further treatment for that. Moving also talking about the clinical presentation. So although the rash can occur in any dermatome, thoracic and lumbar region or dermatome are the most involved. And we know that almost the face involvement is 10% more or less. We're not seeing many cases in the face. In my practice, maybe I saw like 3 or 5 patients in the last 5 years. So mostly the infection in the face is, or let's say rare, but it's not common, and mostly it will become serious. So those patients, some patients will have like a few scattered vesicles, and this can indicate what we call viremia early in the herpes zoster. So this is part of the presentation. I saw some patient, they having like in the elbow, some patient in the leg. So they're having scattered and is not involved in one or restricted to one dermatome. And this is another presentation, and this is one of the serious presentation called herpes zoster keratitis or herpes zoster ophthalmicus. So it will involve the ophthalmic division of the trigeminal nerve. This is one of the serious involvement or serious infection because it is sight-threatening and can cause or lead to blindness. So here is very important, urgent referral or immediate even referral to ophthalmology, and shared management of ophthalmology is very important. What about acute neuritis, which is the pain? So we are talking here about the main reason for visiting. So pain is the most common symptom of herpes zoster. Most patients will describe their pain as, doctor, I have a burning sensation. So this is one of the main complaints or main presentation or expression of our patient. Second patient will say, doctor, I have throbbing pain. 2 days back, I have a lady, she is diabetic, 65-year-old patient. She is describing the pain as stabbing pain. So these are the main 3 presentation of pain because of herpes zoster. Almost about 75% of patients will have a prodromal pain that precedes the rash, and the beauty and the challenge in family medicine that we are seeing in early presentation. I have many cases who came with the prodromal pain only without rash, and then after 5 days they developed the rash. So one male patient, he's 55-year-old diabetic patient, obese, he came to us with right upper quadrant abdominal pain. So in the first day we thought it could be cholecystitis. We did ultrasound, we did some blood tests, everything was normal. So we asked him to come after 2 days. After 2 days the pain was more burning, and he started to have like redness and erythema. The 3rd or the 4th day, he started to develop the vesicles. For sometimes this could be a tricky, and the prodromal pain is sometimes mistaken with other diseases like angina, acute cholecystitis, appendicitis, spinal disease, renal colic, and other diseases that can be mistaken. So the key here is close short follow-up for your patient, plus giving the patient the red flag and safety netting. What about the complication? What is the most important complication in herpes zoster infection? The most common complication, as we know, is post-herpetic neuralgia, which defined as pain persisting 90 days after the starting of infection. It could be a continuation of the pain, or it could start months, even months after the infection. Sometimes the triggering factor here could be a surgical procedure or like abscess or other triggering points or factors. So on examination, usually the affected area of post-herpetic neuralgia may show scarring related to vesicular eruption of the preceding acute herpes zoster infection, and the area will have like some scratching because the patient will scratch because of the pain. Another important point not to be missed here while we are assessing our patients, especially in the history, is that pain can be associated with some other psychological issues or psychological dysfunction, impaired sleep, decreased appetite, and diminished libido. So it's very important to screen for psychological points, as we know that any chronic pain can lead to some psychological disorder. That's why depression is common, especially in elderly, and anxiety is common. So we need to screen and we need to assess our patient. And part of the treatment, as I'm going to mention, sometimes could be cognitive behavioral therapy. The second most important complication, which is almost not common, which is herpetic ophthalmicus. And as we can see here from the left to the right, starting from the mild to moderate to severe and severe cases, usually I believe, at least in my practice, I didn't face any cases like this, but maybe we can hear from our colleague in dermatology. So herpes zoster ophthalmicus, what is the importance of this complication? It is because it is sight-threatening and defined as the involvement of the ophthalmic division of the fifth cranial nerve. The incidence rate of the herpes zoster ophthalmicus complicating the herpes zoster involvement, you are talking about almost 20% or less, and about 50% of the patient experience direct ocular involvement. That's why it's very important as early presentation. If a patient comes with a presentation of unilateral, as we will see in the next slide, unilateral like decreased sensation, pain, acute blurred vision, okay, we shouldn't wait for this patient. We need to refer the patient for ophthalmology, and with or plus close follow-up for the patient, because the patient maybe the rash will occur after maybe 3 or 4 days. As we can see here that the herpes zoster ophthalmicus begin with a prodrome of headache, malaise, and fever. On all of this vague history that we are seeing these cases frequently every day. So which patient should we refer? Which patient should we follow after 2 to 3 days? Which patient could be converted to herpes zoster ophthalmicus, especially if there is conjunctivitis or episcleritis? Another important complication, which is acute retinal necrosis, as I mentioned. Once the patient has an acute blurred vision, plus minus pain, so he is at risk of developing herpes zoster, especially if he is elderly, immunocompromised, and I believe an early referral to ophthalmology is very important. Another, I will not say rare, but not common, I didn't see it that much in my practice, which is Ramsay-Hunt syndrome, herpes zoster oticus. So include a triad of ipsilateral facial paralysis, ear pain, and vesicle in the same area. Ipsilateral, of course, sometimes the patient will have altered taste and some lesion in the tongue, and sometimes there will be some hearing abnormality like decrease in hearing, or tinnitus, lacrimation, and dizziness or vertigo. It reflects activation of the latent virus in the ganglion, which involve the 8th cranial nerve, and the facial paralysis. And this is very important point here, that the facial paralysis seen in Ramsay-Hunt syndrome, it's often more severe than Bell's palsy attributed to herpes simplex virus. What about other neurological abnormality that we need to pay attention to it while we are examining the patient and taking history from the patient? Symptoms of meningitis, symptoms of encephalitis, symptoms of peripheral and signs of peripheral motor neuropathy, myelitis, Guillain-Barré syndrome, and it may cause, or it could be a factor for stroke. Okay, so the last complication, which is bacterial infection, some of our patients will have secondary bacterial infection. The most important two pathogens, staph and streptococcus. So sometimes we need to reassess our patient and to start topical plus minus oral antibiotic for our patients. So close follow-up for those patients, very important. Is it common? Yes, it is common in some patients. So we need to follow up the patient at least after the third day, then after 1 week, then after 2 weeks, and so on. Okay, what about recurrent herpes zoster? We are talking about 5% of the individual may experience a recurrent infection, mostly in female, and mostly after the third infection, we need to look for a secondary causes, or we need to discover or rule out immunodeficiency. That's why I recommend after the third or recurrent episode of herpes zoster vaccine to have a second opinion with our colleague in derma and infectious disease. Moving to the last part of my presentation, which is the management of the acute and chronic cases. So the most important question here before we start the management as a family physician, as a primary health care, is to ask ourselves, can I treat from the beginning or should I refer? And this is based on three main pillars or three main important points. Competency, are we competent to treat those cases based on the facility and based on the severity and authority and the privilege that we have in our center? So when and how to refer? Before we believe that herpes zoster should be referred only to dermatology. But we discovered that if we can manage herpes zoster, sometimes we need to refer for ophthalmology, as we mentioned. Sometimes the patient, elderly patient with immune compromised and with disseminated disease that need admission and IV acyclovir. So those patients need to be directed to ER for admission. And they are almost rare cases. I didn't see those cases before. Pain clinic. Some centers have a pain clinic. So pain clinic maybe will be involved and utilized in some cases, as we will see, inshallah, in the coming slide. And neurology, if there is any neurological complication. And finally, of course, from time to time, ID, infectious disease team, should be with us sometimes with some refractory or complex or complicated cases. So in the management, the pharmacological treatment, we have 4 pillars of treatment. We have the antiviral, pain medication, B12 or B complex, and finally antibiotics. So in each one, we should ask ourselves some questions. In antiviral, which one can be used? We have different antiviral. What is the optimal curative dose? And this is one of the this is an area of improvement, and this is one of the main failure cause of treatment, that sometimes we are giving suboptimal doses. What is the ideal duration of treatment? And this is second cause of failure of treatment. Moving to the pain medication, and this is really one of the important points because the pain will affect the patient quality of life. So should we start with antiviral or as patient needed? So should it be PRN or should we start from the beginning? When to start and what to give and for how long? B complex or B12, what is the evidence about this? Any evidence? What about the practice? Antibiotic, when to give antibiotic? Should we give antibiotic as a prophylaxis or no? All of these questions, we should answer it in the coming slide. So first of all, whom to treat. So patient, uncomplicated patient, immunocompetent, within the first 3 days, they are a candidate for treatment. So antiviral therapy will promote rapid healing of skin lesion and lessen the severity and duration of pain associated with neuritis. So those patients presenting after the 3 days, okay, still we can treat them if they are elderly or they have formed another lesions. And from my practice, I believe still the patient will benefit, even if the patient exceeds 3 days. Of course, if there is crust, almost the patient will not benefit that much. So what antiviral to choose? We have 3 antiviral in the market: famciclovir, valciclovir, and acyclovir. Usually we start and we prefer valciclovir and famciclovir because of the frequency and dosing. It's easy for our patient, it's available, and it's effective. Topical acyclovir, there is a controversial or there is variable data about it, but I believe from practice it helps to soothe and to decrease the pain sometimes. ophthalmic drop. This will be reserved for our colleague in ophthalmology. What about the duration of treatment? Usually it's from 7 to 10 days. But from my experience, my little experience, and we'll want to hear from our colleague their experience, I believe 10 days average is really optimal duration for treatment, and some patients may need 14 days, but I believe 7 days or less, this is a shorter duration, but this is what we found in the evidence, but I believe 10 days could be an optimal duration. What about in pregnancy? Which antiviral we should in pregnancy? The only and the safest antiviral in pregnancy, acyclovir, and I believe pregnancy with herpes zoster, it should be a shared management with ID, dermatology, and always involve the gynae or obstetric gynae doctor with you, so to avoid or to monitor any fetal complication with those patients. What about the pain management? We have two groups of pain management. We have the neuropathic pain management of pain medication. We have 4 main medications: gabapentin, pregabalin, amitriptyline, duloxetine. Mostly we start with pregabalin or Neurontin. Those are the most commonly used medication. What about other pain control? Sometimes in moderate to severe cases, we need to add tramadol, and sometimes we add a topical lidocaine gel. There is not much evidence about it, but it helps the patient. Talking about non-steroidal, paracetamol has limited effect on those cases. Oral prednisolone, I believe there is a valuable evidence about it. Usually as a family physician, we don't use it. Sometimes I saw this different school, some dermatologists, some ID, infectious disease, they are using oral prednisolone with herpes zoster in acute management, but most of the patient will respond to other treatment without steroid. So again, if the patient is not controlled, we need to consider referral to our colleague in pain management. These are the widely or most commonly used. So we are talking about medication for the pain control, Neurontin, Lyrica, Cymbalta sometimes, okay, amitriptyline work very good, and tramadol with some patients. So the question here, or the point here, that I believe in it after many cases, I saw many cases, after many times discussion with our colleague in pain management, that the earlier starting the pain medication from day one, the better the pain control and better the quality of life of our patient. Of course, until now, we don't have strong evidence that early starting of neuropathic pain will prevent post-herpetic neuralgia, but it could decrease the symptoms of post-herpetic neuralgia. So what about vitamin B12? Still, we have variable data and controversy about using B12. I believe from my practice and the practice of other colleagues, it could help because acute neuritis can be managed and decreased by using B12. Still, we need a further investigation for that. What about antibiotic? As we said, and this is the 4th pillar, topical plus minus oral antibiotic could be used in secondary bacterial infection, not as a prophylaxis. Sometimes we are seeing cases, they are giving like fusidine, they're giving oral antibiotic from the beginning. They don't have any bacterial infection. So it is not for prophylaxis, it is just for those patients with secondary bacterial infection. What about post-herpetic neuralgia management? Simply in 2 slides. Initial management, we start with gabapentin or pregabalin. These are the mostly used medication. If the patient is not responding or the patient don't prefer or difficult to prescribe because both are controlled medication, we can go to tricyclic antidepressant like amitriptyline. For those patients who don't prefer or they don't respond or they don't want to be started on those medications, some anti-seizure medication like valproic acid and carbamazepine could be used, but I would prefer for those 2 medications to be started by our colleague in neurology. Selective serotonin norepinephrine reuptake inhibitor like duloxetine, Cymbalta could be used. Of course, if the patient still not improving, please refer to our colleague in pain management for other modality of treatment like oral or transdermal opioid, interventional and surgical approaches are Botox injection, neuromodulator, and other radiofrequency and other modality of treatment that is almost done in the pain clinic. Other analgesic like paracetamol, non-steroidal almost has limited efficacy in post-herpetic neuralgia. Please don't forget cognitive behavioral therapy, and sometimes maybe you can refer your patient to psychology if you don't have time or if you are not competent in dealing with those patients, especially those who develop like depression or anxiety, or any psychological disorder. So moving to talk about the prognosis. So the pain of post-herpetic neuralgia may persist, as we know, for months or years. And the importance here, we need to discuss with our patient. We need to clarify this to our patient that post-herpetic neuralgia can last longer with you. And this will improve patient satisfaction and quality of life. Until now, there is no definite way to prevent post-herpetic neuralgia other than, as we know, early starting of antiviral treatment. And here comes the importance of early diagnosis and, of course, vaccination that will, and we'll hear about it and we'll discuss it more and more in the coming slides. So take-home message, herpes zoster is not just a rash. Herpes zoster, it is a disease that can change the patient's life. Patients usually come to us because of the pain, not because of the rash, most of the time. Optimal dosing, optimal pain control, in my opinion, it is the missing link in the management of herpes zoster and post-herpetic neuralgia mostly. Our role as a primary health care and family physician is early diagnosis, early treatment, early referral when needed. I want to remind myself and all of you that herpes zoster is not a disease just affecting only the body. It has another aspect. It can affect the patient psychologically, socially, and financially. Last slide, we need to remember that herpes zoster is mostly about preserving and improving the quality of life of our patients. Thank you so much.
Thank you so much, Dr. Badr, for this very illustrative presentation that covers most of the topics. In fact, highlighting all the parts of screening, management, and even dealing with the complications as well. So thank you so much for this wonderful presentation. And I would like to remind all the attendees that we are attended by 1,000 virtual healthcare providers. So I would like to invite them to make sure that they are registering their registrations correctly in order to have the CMEs. And please put your Q&As, questions in the Q&A box so we can have their questions answered at the end of this session. So as you said, Dr. Badr, our role is to have the proper diagnosis, the proper treatment, and the proper referral. But before that, we have to ensure that we have a special tool in primary care is the prevention. So in prevention will be summarized in terms of the proper vaccination for the proper eligible populations who are at risk to have the infection. So without any further ado, I would like to invite the second speaker, who is Dr. Isra Muhammad Turkestani. She's a consultant dermatologist, a board-certified dermatologist and venereologist, and in the International Medical Center. She holds the bachelor degree of medicine and surgery from Al-Qura University and Saudi board dermatology training in Jordanian board in the dermatology and venereology. Dr. Isra is one of the authors of the dermatology educational book الأجوبة الشافية لمن سأل عن أمراض الجلد الشائعة. So she's going to highlight another interesting part of our topic, which is findings and practical case from the clinical practice. So on your behalf, ladies and gentlemen, I would like to welcome Dr. Isra on the podium here to start her presentation.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ashraf, for the warm introduction, and thank you for inviting me to be here with you today in this scientific meeting. Today I'm going to present to you a live case from my practice. This patient came to me on the last Wednesday, so I had to change the lecture to include him in this activity. A non-case of diabetes, hypertension, dyslipidemia presented to ER 7 days before seeking dermatology OPD, complaining of severe right flank pain of 1-day duration. The patient was investigated in the ER with laboratory investigations and imaging, as he was suspected to have appendicitis, renal colic, or cholecystitis. Okay. The patient was afebrile upon presentation to the emergency room and vitally stable. CT renal stone study showed, as for the gallbladder, it showed fundal radiodense sedimentations of small stones, a remarkable wall thickness, no pericholecystic fat stranding or fluid by time of examination. As for the biliary tract, biliary duct, there was no significant dilatation. The study conclusion showed a calcular gallbladder without cholecystitis. General surgery were consulted for the patient. He had negative Murphy's sign, no leukocytosis, normal serum amylase and lipase levels. Acute cholecystitis was ruled out, and the patient got scheduled for elective cholecystectomy. After the initial ER visit, the patient kept visiting the emergency room on the subsequent days for the same initial complaint, severe right flank pain for 5 days duration. He described the pain as a dull, aching, constant pain with no radiation to any other area in the body. The patient reported that the pain did not improve on all analgesics prescribed to him by the ER. On the last ER visit, day 6, his emergency doctor prescribed him valacyclovir 1000 milligram Q8 hours for 7 days and referred him to dermatology to confirm the diagnosis of herpes zoster. The following are pictures of the skin rash of the patient presentation when he came to see me in the clinic last Wednesday, day 7 from the onset of the symptoms. Okay, I will go through the pictures. You can take seconds to appreciate the lesions, and I will describe the lesions to you. Okay, so starting from the first picture, we can see that there is ill-defined erythematous plaque with multiple vesicles on an erythematous base, not crossing the midline, the posterior midline, affecting multiple dermatomes, mainly T9 and T10 and part of T11 as well. As you can see here, there are different stages of the vesicular rash. Some of the lesions had some clear fluid, and some of the lesions had turbid pus-like fluid. Here we can see that the skin rash also affected the level of umbilicus, which is T10, and again did not cross the anterior midline. So our patient, sorry about the description. Yeah. As for the description, patchy indurated erythema in the involved dermatomes, grouped vesicles on an erythematous base, plus minus lymphadenopathy. Vesicular involution, we can see vesicles at all stages. Initially, they can be clear, but eventually they could become cloudy and might rupture and crust and eventually involute. Slow resolution, usually without visible sequelae. However, that scarring can occur if deeper epidermal and dermal layers were compromised by patient's excoriation. So our patient had herpes zoster on the right T9, T10, and T11 dermatomes. The lesions did not cross the anterior or the posterior midlines. Lesions in general can cross the midline in immune compromised patients, and usually they can affect multiple dermatomes, not just one or two dermatomes. So a take-home message, herpes zoster almost always start with the prodromal sensory phenomena lasting 1 to 10 days. Average is 48 hours, which usually are noted as pain, itching, or paresthesia. Prodromal pain can be described as muscle, toothache-like, headache, iritis, pleurisy, brachial neuritis, cardiac pain, appendicitis, or other intra-abdominal disease or sciatica. Pain is sometimes described as burning, throbbing, stabbing in nature. Detailed history and physical examination is always important, and skin examination with each follow-up visit it must be done. Thank you. As for my patient, after I saw him in the dermatology clinic, I extended the duration of valacyclovir to include the additional 3 days. So he was prescribed for 7 days. So I give him total of 10 days because the antiviral treatment, as Dr. Badr mentioned, was not started early. And I referred him to neurology to adequately control his pain. Thank you.
Okay, thank you so much, Dr. Isra, for this clinical case, which was a real world evidence of a real case of herpes zoster. And now we will move to the third part of our session for the third speaker, Dr. Lama Abdulaziz Ramal. She's a consultant for medicine and diabetology in Primary Healthcare Ministry of National Guard Health Fair, assistant professor in King Saud bin Abdulaziz University for Health and Science, Ministry of National Guard Health Affairs, and the topic will be the herpes zoster prevention decade of protections. So I will just leave the floor for you, Dr. Lama. Thank you for.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the IMC to invite me to be a speaker in the 33rd Family Medicine Club. And it's my pleasure to be a speaker today about very important disease, which is now it's common and it's preventable. And now with the health transformation and all the powers to prevent diseases, not only to cure, it's the goldstone part of family medicine. So we are happy now in this few years to be one of the leaders in a healthcare system to prevent, not to cure. So my topic today about herpes zoster vaccination in adults. And adult immunization is a big topic. And a lot of new guidelines and national immunization program, which is the zoster vaccination, Shingrix, is a national Saudi program for immunization. It's very important to be a part to know which patient our target for immunization, what are the indication, the age group, and the proper administration of the vaccine. I will move on. Okay, this this clear? Okay. My agenda today, it's 5 parts. The first part, what is the clinical impact of shingles on the patient? Then why is it important to prevent shingles? How was Shingrix designed, and what is the clinical profile of Shingrix? And last, how can we implement Shingrix in your practice, which is a very important part of the presentation. What is the clinical impact of shingle in the patient? Dr. Badr, he explained it very well, and I enjoy his picture and his lectures. So more than 90% of adults age 50 and more infected with the varicella zoster virus and are at risk for shingles. You can see that varicella, it starts like an infection in the childhood, then it becomes latent in the dorsal root ganglion, and at time of reduced immunity, the zoster start to appear. And here the challenge, we are facing a lot of immune response variation across the ages and for different causes, and we will explain why the immunity decrease in our patient or our population, either for steroid use, for COVID outbreak, for age-only related, disease-related. Up to 1 in 3 people will develop shingle in their lifetime due to varicella zoster reactivation, which is high. Incidence rates are similar between countries, overall rate around 6 to 8 per 1,000% per year. And each year there are an estimated 1 million new cases of shingles in the United States, 1.7 million in Europe, and 1.5 million in China. So as Dr. Badr mentioned, the different presentation of shingles between acute presentation, complication, so I will not repeat it again, it's well explained. And the important number here, the recurrence rate, as you can see, it is 6 to 10% of patients who experience zoster one time, he will have it again. Accidentally today in the morning, I faced one patient with a shingle with zoster infection, and she told me I cannot sleep for 2 weeks because of the pain, whatever medication I was. So I am sure that I will take my vaccine after I finish. And you can see how the pain is severe. This is the Meagle pain questionnaire. And the pain scale from 0 to 50, you can see the comparison with the labor pain, or female knows the labor pain, how it's severe. So you can see that labor pain is 20. The post-herpetic neuralgia is more than labor pain. And also the herpes zoster itself, it's more than 20, it's more than labor pain. The percent reported inequality of life, around 60% cannot sleep from the pain. More than 50 cannot enjoy their life, their activity, they have a bad moods, and with walking disability. The next step, why it is important to prevent shingles. You can see here the immune system. It's changed over the individual life. We are not static individual. We are not a machine. We are facing a lot of difference in our immunity status. And we need to be sure that as a physician and nurses and healthcare providers, that at the time of 50 years old, you can see that the immune system will decrease. Age-related decline in immunity, it is a dominant driver of shingles. As you can see, the cellular immunity here with the age. When we're born, our immunity is very low, then we are more prone to chickenpox. This is why chickenpox now one of the immunization in the childhood. Then when we get more, the cellular immunity, it needs a varicella zoster specific cellular immunity may be boosted periodically with varicella zoster exposure, reactivation from latency. Then after that, the cellular immunity decrease. This slide will show us the burden of shingle increase with the age, with a sharp increase from more than 50 years old of age. This is a study, it's a multinational study from Australia, France, and you can see that most of the country, the age, it's related to the age. More shingle with age more than 50. So what are what are the top age variety of factors that lead to increased risk patient to have shingles? We can see that COPD and bronchial asthma patients have 30% risk of increase of shingle. COVID-19 patients have 15% increased risk. طبعا diabetes he's the big man for this. More than 40% of diabetic patients have increased risk of shingle. This is why ADA recommend start giving Shingrix vaccine for diabetic patients. For sure, chronic renal disease, autoimmune, steroid, and HIV patients. COVID-19 may also be a risk factor for shingle reactivation. It was reactivated in 15% of patients diagnosed after COVID-19, and the risk of hospitalization reached to 21%. Chronic respiratory conditions are associated with increased risk of shingles, as we mentioned, bronchial asthma, COPD, and two more increased risk of herpes zoster-related hospitalization in COPD patient. The severity of shingle and risk of complication is increased in a patient with diabetes. You can see the patient with poor glycemic control have high risk of, I don't have arrow, okay. They have more risk of post-herpetic neuralgia by 19%, more increased risk of persistent post-herpetic neuralgia, more than 6 months, 18%, and 60% increase of hospitalization. Okay, now we will move to the second half of our presentation. How was Shingrix designed? Why we should know this part? Because from this information, we can know what is the component of vaccine and what are the target age group for this. Shingrix is a significant advance in shingle vaccine. And as I mentioned, the target group is more than 50. We will go now to the component of the vaccine. It is made from spike of glycoprotein E antigen with adjuvant system. The cornerstone is the adjuvant system. The adjuvant system gives this vaccine the prolonged effect from more than 10 years. So this adjuvant system unique, and it's crucial to know it because this is the difference between a varicella zoster vaccine and other vaccine, the prolonged effectiveness. As I mentioned, it's made from glycoprotein spike, and it's which is a very important role in the viral infection. And it targets both humoral and C cell. Rationale for selection adjuvant system, it will make it stronger, broader, and you can see the difference between two vaccines. The one with non-adjuvant system, the effects in times is less compared with the adjuvant system. It makes it stronger, broader immune response. What is the clinical profile of Shingrix? They did a study in Shingrix, two large pivotal phase 3 clinical trial, comparing the effect on a different age group, 50 and above and 70 years and above. It was randomized observer, blind, placebo, multi-center, multinational trials, more than 18 countries involved. The first ZOE the subject enrolled more than 16,000 patients, and the ZOE 70 for 70 years old was more than 14,000 patients, and the study endpoint was the efficacy against herpes zoster, post-herpetic neuralgia, and other complications. So what they noticed that both age group have more than 90% efficacy in protection against herpes zoster infection. And even the more than 70 years old who have 91 protection, the 10% who got the zoster infection, it was less severe, with less severe post-herpetic pain and hospitalization. And you can see here also the efficacy between two age groups. After they finish the first study, would take 4 to 5 years old, 4 to 5 years duration, they would like to extend the duration of the study to see how much can protect this patient up to 10 years. So they continue the same population, they extend the study for 10 years. So the efficacy was up to 10 years old, 10 years follow-up, 89% efficacy against shingles, which is big percent. Okay, as all vaccination have some local reaction. 60% of patients will have pain, redness, swelling, fatigability, headache, which is common in all vaccination. And no increased risk in a serious adverse event for patients taking Shingrix. Now the challenging point and why we present this meeting today, how we can implement. The implementation really is a change process. Change is a process, it's not one step. We cannot change our world in 2 or 3 months or 6 months even. So, but we should start. We should put one step forward to continue and to make change. For some information related to vaccine itself, the storage should be refrigerated, don't freeze it, store it in 2 to 8 degree. Shingrix is supplied in 2 vials for reconstitution. One vial have a powder, the other vial have the solution, and it should mix for intramuscular injection only. So Shingrix is indicated for prevention of herpes zoster in adult 50 years of age or older and 18 years of age or older at increased risk of herpes zoster. Contraindication only for hypersensitivity to active substance. This is very important slide. It should be 2 doses. 2 doses for Shingrix are required to induce strong immune response against varicella zoster. 2 doses generated a 4-time increase in a cellular immunity response versus 1 dose. So here you can see the vaccination schedule. Each patient vaccinated in the first dose in the 0 month, they have a time to have the second dose, which is not a booster, this is the second dose, between 2 to 6 months. Data support co-administration with other vaccination, like influenza vaccine. This is what we do it in our clinic. We give both flu vaccine and Shingrix vaccine together, pneumococcal PCV13 and DPT. Current guidelines and recommendation for Shingrix for general population above 50, Saudi Arabia Ministry of Health, as I mentioned it's a national program. In America, they put it in the US advocacy committees, in Europe, in Australia, but then the very important message is the diabetes, the ADA. It's now in the ADA recommendation for diabetic patient, and in the asthma, we is COPD. So this is the summary. Shingle is a painful disease that can have serious and long-term complication, age-related decline in immunity, increased risk of shingle. Shingrix is specifically designed To overcome decline in immunity due to age, Shingrix delivered up to 97% efficacy against herpes zoster in more than 50 years old and has acceptable safety profile. Store Shingrix in the fridge for 2 doses to be administered 2 to 6 months apart. And thank you.
Okay, thank you so much, Dr. Alama, for your presentations. And I would like to invite all the speakers on the podium here on the stage so we can start the Q&A session. We got some questions from our audience online, and I'll be very pleased to forward it to our speakers. So there is an observation, in fact, and this is exactly what I'm sensing from our own practice. After the introductions of the shingles vaccine, we are seeing more cases of herpes zoster. So what is your comments, anyone? You know, in the past 1 year, I saw 5 cases. In 28 years of mine, I didn't see that much of cases.
Actually, in dermatology, this is okay. Yeah, we're seeing herpes zoster on weekly basis, like from the simple cases even to I had one patient who had disseminated herpes zoster. I referred her. She was referred to me from our colleague in rheumatology. She's a SLE patient. She was on multiple immune suppressive medications, biologic treatments, oral corticosteroids, and she was referred to me because of suspected lupus rash, because the rash was all over her body. She came on a wheelchair. She actually was crying from the pain. She couldn't tolerate the pain. When I saw her, I saw that she had multiple dermatomal involvement of herpes zoster, and I asked, her daughter was also a family doctor. She was feeling guilty that she didn't give her mother the vaccine, and she didn't know that she should have been on the vaccine before starting all these biologics. So I referred her to the emergency room, our emergency room, and I wrote a full comprehensive note, and they admitted her and consulted pain management.
Okay, Dr. Issa, is it a common case that you are seeing throughout the year, or there is a certain season for it, or any associations with COVID, as you have said in your presentation? That was
I didn't see any association with COVID, actually, and we're seeing herpes zoster throughout the year in our clinic. I don't know if you're seeing it maybe with the flu season, but almost every week I have 1 or 2 herpes zoster patients. This is just me, and I'm sure all my colleagues, they're seeing their share also of herpes zoster patients. And some of the patients I saw from my previous practice were pediatric patients with the herpes zoster affecting the lumbosacral nerves. And taking the history from the parents, I asked the father. He said he couldn't recall if his child had chickenpox. Maybe she had fine viral illness or something.
Okay, so let me ask you a question, because this is one of the questions which has been asked, but it might come later. But as you have said it now, what will be the differential diagnosis for the skin rashes that we encounter with herpes zoster? So what are the different varieties of disease?
Differential diagnosis. Herpes zoster is almost always like have a characteristic presentation. The grouped vesicles under erythema, and affected dermatome, not crossing the midline, whether it's anterior or posterior. This is in the most typical cases, not in immune-compromised patients. And we can also sometimes, if the patient come in the early stage with just urticarial lesions or papules, we can put contact dermatitis, eczema, allergic contact dermatitis. Yeah, it's most of the common differential diagnosis.
Psoriasis, gut-tape psoriasis?
Not so much, because psoriasis usually have the classic silver white scales on top of the skin lesions.
Okay, thank you so much. Dr. Badr, there's a question. You know that post-herpetic neuralgia is a very devastating complication of herpes zoster. If there is any way to prevent it after the infection?
Prevention after infection, I don't think there is a specific, until now, there is no specific modality of management or treatment to prevent post-herpetic neuralgia and after infection. But what we know from all the studies, from all the literature, that the earliest starting the antiviral treatment, okay, could help to improve the prognosis of and the severity of developing or post-herpetic neuralgia. This is one aspect. Second aspect, which is again a belief and a practice, and I believe we are not exposed that much to the literature in the pain management. I have many discussions with our colleague, our consultant in pain management. They believe with many cases that they are seeing on daily basis in treating with the neuropathic medication, especially we're talking about the gabapentin, pregabalin, selective serotonin reuptake inhibitor, or selective norepinephrine reuptake inhibitors. They believe that it could help to improve the prognosis and severity of post-herpetic neuralgia. But still, we don't have that much strong data about it.
Okay, thank you so much. Dr. Lema, after having the infection of herpes zoster, when to give the vaccine?
We recommend to give vaccine. The CDC recommend vaccination after 1 month of acute stage. So if he finished the acute stage, after 1 month, he can take the Shingrix vaccine to prevent the recurrence.
Okay.
Yes.
There was different schools, they're saying 2 months, and some other schools, they can eat in 1 year. So which one we should follow here?
We are going with CDC. If there is a complete resolution, after 1 month, it's safe to be administered. And if you, I want to add one point about your first question regarding why we are seeing now more herpes zoster, because of diabetes. As you know, diabetes now it's growing up and the prevalence increasing, and pre-diabetic are very high prevalent now. So this is, I think, one of explanation more than COVID.
Yeah, and in fact, there is another factor, which is immunosynthesis, which is we have growing populations, and while we grow older, we lose our immunity, competency to tackle the disease. So as we are getting into geriatric population rather than young populations, definitely our community will be immune compromised, and this will add on top of what we have. So if the patient missed the dose, the second dose, within 6 months, so when you will be giving the second dose?
The recommendation is he can take it. Still, he can take it after 6 months, and he doesn't need to repeat again the first.
So one single dose.
Yes, but the better effect and the better efficacy within 6 months.
Okay.
Yes.
Do you think that the vaccine will be just only once to be given, or you said there is a trial, Zoe, for example, 10 years, which gave 89% the immunity for 10 years. But what's after the 10 years? If there is any possibility to repeat it again, or
still the recommended studies give us 10 years, room of 10 years. After 10 years, we will see what will happen. If there is a new evidence to repeat it after 10 years, we will see.
Okay, Dr. Badr, antibiotics in the management of herpes zoster, when?
Yes, it depends. That's a very important question, because one of the mistakes I believe in the practice, sometimes we are seeing that maybe because of difficulty in follow-up or something like that, is giving the antibiotic as a prophylaxis. We shouldn't give antibiotic as a prophylaxis, okay? It's a clinical judgment and a clinical assessment. That's why you need to follow your patient closely and assess the patient, not just asking. Sometimes little bit we are shy to examine the patient. Okay, no, please go and examine the patient, and based on your examination and clinical assessment, you will decide what and when to start the antibiotic. Should we start with oral alone, with topical alone? I believe both will help the patient, even the topical, because it will soothe and decrease the pain a little bit.
Okay, thank you. Dr. Isla, how long is the post-herpetic neuralgia will last? For years, for months, for years? I have one of my patients who is 91 years old, and she's having 9 years of suffering from the post-herpetic neuralgia. We started her on pregabalin, gabapentin, and even tricyclic antidepressant with combinations. And again, we started using the lidocaine patches, but it's still, the pain is there, in spite of having a clear, clean skin, but the pain is there. So the reductions of pain was just only 30% of the total perception of the patient. So that's why this was a quite challenging, management of this kind of pain.
Yeah, actually the pain can persist for years and it becomes chronic and it will stay there because the nerve is just irritated. And that's where the pain management part come in there. They can do, I think, nerve block, or they can do certain procedures because these patients really suffering from pain. They cannot sleep, they cannot sit, they cannot attend their social gatherings, and pain management with medications only, I don't think is for everyone.
Okay. So one of the questions I think many of our audience are asking about the availability of the vaccine. Is it available everywhere in primary healthcare, in Ministry of Health, in private sectors?
Yes.
Covered by insurance?
I don't know about insurance, but it's a national program. It's available in all Ministry of Health, primary healthcare, and also in all governmental. I think also in the private. It's available. Sure.
Yeah.
Allow me, Dr. Ashraf, just from this, from this place and from this scientific meeting, we should insist that this is a patient right. So it should be covered by the insurance. And sometimes, let us say that 50 to 70% of our patient is covered by the insurance. But if it's not covered by the insurance of the patient, or the insurance reject that, it is the patient right to ask for this coverage, because this is a national programs and it should be covered by the insurance. Just returning back to the pain management, I believe one of the main point here, as mentioned by our colleague in pain management, what make a difference in post-herpetic neuralgia is early intervention. Thanks God, in the last 3 years, we have different modality of treatment in pain management, including neuromodulation, including radiofrequency and other injections, and even transdermal treatment that really could help in improving the prognosis of post-herpetic neuralgia. And another point that we are missing a little bit, okay, and with our colleague, the nursing colleague is here, we are missing too, sometimes specifically with patient with herpetic neuralgia, to do a full detailed pain assessment. We should have a detailed pain assessment in each visit. Okay, for our colleague, we have some tools now. Okay, we are using, like in orthopedic and others, we are using new tools to assess the pain of our patient. And based on this assessment, we need to take a quick action, not to wait for, like increasing the dose of gabapentin or Lyrica or whatever, or to add another medication. I believe going parallel with different direction, with different pain modality management, I believe this is the way to deal with post-herpetic neuralgia.
Thank you so much, Dr. Badr. I think this was all the questions, but before we close, I would like to ask each one of you to deliver a single statement, recommendations for our colleagues who are primary care and family physician. What is the pearls of recommendation that you would like to tell them? Brief.
So in one word, don't forget the missing ring, which is optimal pain management.
Thank you.
Start vaccination.
Yeah, good.
I wanted to mention regarding herpes zoster keratitis. We used to study, this is a common question during our board exams. If you see a patient with vesicles or early lesion on the tip of the nose, could be an indication of ophthalmic branch involvement. So you can refer the patient early, just don't wait for the whole blown picture to develop.
Okay, thank you so much. So with this, ladies and gentlemen, the colleagues, I would like to thank on your behalf our guest speaker who have been fruitfully and successfully enriching our scientific session with a lot of insights and rich information. Dr. Badr Bilhim, Dr. Isra Turkestani, Dr. Lama Ramal, and special thanks goes to GSK for sponsoring these wonderful presentations and gathering. I cannot forget the Saudi Society for Family and Community Medicine who are supporting this kind of scientific gathering all the time with special focus, and a special thanks goes to the IMC Family Medicine Department represented by Dr. Badr as a chairman. And I would like to thank also ملتقى الخبرات لتنظيم المعارض والمؤتمرات for their wonderful contributions. And whatever we have learned today, ladies and gentlemen, I hope that we can carry this rich information tomorrow onward and to put in our clinical practice while we are dealing with immunocompromised patients. Our role is to screen, identify those patients at risk, to diagnose, to treat, and to prevent the complication, and then finally to refer the patient to our colleagues. With this, I would like to thank you all for your attendance. Until we meet again next month in another session of IMC Family Medicine Club, I wish you a wonderful night. Thank you so much. Okay, please, we'll be having the dinner next door here. So please, let's go all of us together.
you.